Good afternoon, or good morning, sorry. My name is JJ Hue. I'm a general surgery resident at University Hospital's Cleveland Medical Center in Cleveland, Ohio. I want to thank SAGES for allowing me to present our work titled A Comparison of Robotic and Laparoscopic Minimally Invasive Adrenalectomy for Adrenal Malignancies. Dr. Tao has several disclosures, but none of these have impacted our work. All other authors on this project have no disclaimers or sources of funding. In recent years, due to the increased utilization and improved spatial resolution of cross-sectional imaging, the incidence of adrenal pathology has increased. For patients who are diagnosed with localized adrenal cancers, guidelines typically recommend open adrenalectomy. However, several recent retrospective reviews of administrative databases have shown that minimally invasive adrenalectomies are being performed for patients with adrenal cancers. Additionally, robotic adrenalectomies are becoming more popular. However, we identified a paucity of literature comparing laparoscopic and robotic resections, specifically among patients with adrenal cancers. To further answer this question, we utilized the National Cancer Database from 2010 to 2016. We identified patients with localized adrenal malignancies, including adrenocortical carcinoma, malignant pheochromocytoma, and other adrenal carcinomas. Importantly, we excluded patients with node-positive or metastatic disease at presentation. For this analysis, we only looked at patients who underwent a starting minimally invasive adrenalectomy, and they were stratified by robotic and laparoscopic resections. For our primary outcome, we looked at the intraoperative conversion rate. Past studies have shown that conversion from a minimally invasive adrenalectomy to an open approach is a poor prognostic indicator. Thus, we chose that as our main outcome. Additionally, we looked at other perioperative and long-term outcomes, including the positive margin rate, duration of stay after surgery, and overall survival. To account for confounding, we utilized multivariable models, and to further explore our primary outcome, we utilized marginal standardization, which takes data from a multivariable logistic regression and calculates adjusted probabilities of our primary outcome when weighting on a different variable, such as size or laterality in our case. Here we see some data comparing the laparoscopic and robotic groups. Not pictured here are the demographic variables, which are well balanced between groups. As you can see here, the diagnosis and laterality were fairly similar between the laparoscopic and robotic resections. Additionally, median tumor size was not statistically different, and I just want to draw your attention to the fact that approximately 20% of all tumors which were approached with a minimally invasive adrenalectomy were over 10 centimeters in size on final pathology. Here we'll get into our marginal standardization, which again looks at the likelihood of conversion, now weighted by size. So moving from left to right, we see a stepwise increase in the probability of conversion for tumors less than 5 centimeters, 5 to 10 centimeters, and greater than 10 centimeters. And although there is a little bit of overlap in the 95% confidence intervals, it does appear that robotic resections were associated with a reduced probability of conversion for these adrenal cancers. Again, here we'll see a similar slide with marginal standardization, but now looking at laterality. As we would expect, right-sided adrenal cancers had a higher probability of conversion as compared to the left. And again, there still appears to be a little bit of overlap between the confidence intervals, but again, we see that robotic resections may be associated with a reduced probability of conversion. Here we'll move on to sort of the formal multivariable logistic regression, again looking at our primary outcome, intraoperative conversion. And as you would expect from the last two slides, robotic resections were associated with a 61% decrease in the likelihood of conversion as compared to laparoscopic approaches whenever controlling for important other covariables. Additionally, right-sided tumors and greater tumor size were associated with an increased likelihood of conversion. Moving on to some of our secondary outcomes, here we see margin positivity. The starting operative approach, either laparoscopic or robotic, was not associated with an increased likelihood of positive margins when controlling for other factors. However, independent of that approach, either laparoscopic or robotic, procedures which required conversion were associated with an over twofold increase in the likelihood of positive margins. We see similar data here for the length of stay over 5 days. Again, the initial approach, robotic or laparoscopic, was not associated with an increased likelihood of an extended length of stay. But again, as we would expect, conversion was associated with a very significant increase in the likelihood of extended length of stay. And lastly, for overall survival, again, robotic or laparoscopic was not associated with survival outcomes. However, patients who required conversion did not fare well and had a 50% increase in their overall mortality when controlling for other important variables. So in conclusion, robotic adrenalectomy was associated with a reduced likelihood of conversion relative to a laparoscopic approach for patients with various adrenal cancers. So if a surgeon is not planning to perform an open adrenalectomy, however, adrenal malignancy is still a possibility, robotic adrenalectomy may be the preferred approach. This is important, especially for adrenal tumors, as officially diagnosing a patient with a malignancy preoperatively can sometimes be difficult. Thus, surgeons may be performing minimally invasive adrenalectomies unknowingly on adrenal cancers. And lastly, conversion, as has been previously shown, was associated with poor perioperative and long-term outcomes, and thus this should be avoided if possible. However, we would like to note that this is likely a marker of disease biology and aggressiveness, not necessarily the technical act of converting from a minimally invasive to an open approach. I'd like to thank you all for your attention. If anyone has any questions, I'd be happy to answer them.